Support for Nevada Week is provided by Senator William H. Hernstat, Cashman Equipment, DeCastro Verde Law Group, Valley Electric Association, and additional supporting sponsors.
Hello and welcome to Nevada Week. I'm your host, Casey Smith. Thank you very much for joining us. Nevada ranks 51st in the United States, dead last, when it comes to mental health care issues, according to Mental Health America, a nonprofit group that says the Silver State has a high prevalence of mental illness and limited access to mental health care. Now that access is about to get even more limited. A new state policy is limiting the number of therapy sessions a Medicaid patient can receive without state approval. Now that's Medicaid. The old number was 26, or one a week for half a year. The new number is 3. The reason, according to state Medicaid officials, is to cut down on fraud and better protect the quality of service provided. Joining us to discuss what all this means to Nevada, its mental health patients and taxpayers, is Cody Finney, a deputy administrator of the Nevada Division of Healthcare Finance and Policy. Her department oversees state Medicaid disbursement and policy. Devin Brooks is the CEO of Brooks Health Services and leads a coalition of North Las Vegas mental health care service providers. Devin is concerned how this will impact patients. Stephen Brotman is here. He is an industry advocate and consultant and is here to add context to the related policies and regulations. And Stephanie Huey is CEO of Eliminations Counseling and Homestead Counseling. She will speak to the impact on service providers. Thank you all for joining us very much. Cody, I'd like to start with you. What exactly is Medicaid? Because it's a little convoluted to the public. And what exactly is covered in Nevada through Medicaid?
So thank you, Casey. Medicaid is an insurance program for people who otherwise would not have health insurance. We're covering about 652,000 Nevadans at this point with Nevada Medicaid between our fee-for-service programs and our managed care offerings. So we insure a great number of people, and our mission is to make sure that those people get the services and care that they need in order to get and stay healthy. And the program is a partnership with the federal government. So about 65% of those costs on average come from federal dollars. So it's a state-federal partnership to pay for those services.
But it's up to the state to disperse it, correct?
It is up to the state to disperse it, yes.
How many of those 652,000 Medicaid patients would be termed mental health patients too?
Wow, that's an excellent question. It depends on how you define mental health patients. So if we're talking about anybody who's getting behavioral health services, that's going to be a fair number of people in the multiple thousands range. If you're talking about those who are requiring intensive service provision, that's a fairly small number in the about 5,000 range.
So varying degrees. Okay, Stephen, what types of mental health care is provided through Medicaid and what isn't?
Yeah, I mean, basically we have this 360-degree service profile to deliver individual therapy, group therapy, neurotherapy programs, things called intensive outpatient programs. I specialize with outpatient mental health clinics. We're finding some old school delivery models to help some new school problems, so to speak.
Okay, now the policy is changing, as we stated. So, Devin, if you could walk us through how a Medicaid patient obtained access to mental health care before this policy kicks in. The policy kicks in officially August 15th.
Yes. So typically when you're, just give an example, let's say we have a 13-year-old girl. She's in CPS custody, and she's just been identified that her foster parent has just molested her. She hasn't been on her psychotropic medications, and she's in a process now where she just tried cocaine for the first time. We have a caseworker comes in, gets this person an assessment, and from us getting them an assessment, it depends on what type of MCO they may have. So now we have
MCO,
so managed care organization. Managed care organizations partner with the state.
Gotcha.
They're there to try to assist with managing the care and managing the finances. But one of our issues is that if we're not paneled with those MCOs, and it puts us in a place where we don't have access to get to those recipients. But back to the young lady, as far as right now, sometimes if she comes in the next day, hopefully we'll get her an assessment. From her receiving that assessment, we take about 2 days from an administrative standpoint for the clinicians to get that assessment back to us. So now we're about 3 days in. From there, we have a 24-hour turnaround where we prep the information to prepare for the insurances such as CMS. We're looking at about 5 days, about 5 business days, so about a total week, including the weekends.
That's now. That's before the new policy kicks in.
That's before the new policy kicks in. And then from there, Medicaid has up to 5 days from there to give us an authorization. So you're looking at about 14 days for us from the time of us potentially getting this young girl in for a comprehensive assessment to us being able to receive services. Now, this is granted if you are part of the MCOs, but if you're not part of the MCOs, and let's say that this patient is a Medicaid full fee-for-service patient, they still have the right to then deny the services. So now this patient has been waiting 14 days. You have to pay your providers to take this service on, and then by the 14th day, they deny the service. If they approve the service, then you're able to provide the services from that point on, and maybe even retro from that state. But what we took advantage of was having access to those available resources, or if we have to go through a denial process after the 2-week process of getting them in, that we would have those available to us. Now we're limited down to those 3.
So Stephanie, you deal with much the same thing. How was it from your standpoint with the old policy?
With the old policy, similar to what Mr. Brooks is saying, when a client does come in, we do check insurance eligibility to see if the client is eligible for insurance. And if they are, obviously we schedule them for a comprehensive assessment with a clinician. And at that time, the clinician assesses the client and creates a treatment plan of sorts, and then we can continue services from there. Whether we request that the client receives therapy sessions or any of the other services that Mr. Brotman mentioned earlier, that's all included in the treatment plan. A lot of those services do not require prior authorization. We just kind of schedule the client when they're able to come in, and then we continue with those services. We have the limitations that were set, the 26 sessions for children and the 12 for adults, and we just implement the services. And so this is before this new policy will take place. Obviously, those limitations now will decrease down to 3 sessions,
right.
And that's where the discussion is right now.
And as we said, it starts August 15th. And Cody, you're about to ask a question, that's fine, but what is the main purpose of this? That's the first thing I'd like to ask.
Thank you. The purpose is really for us to partner with all of our provider organizations and make sure that the clients are getting the right service at the right time. So the description that Mr. Brooks gives is very helpful. I do want to emphasize that initial assessment is not part of the 3 visits. That's a separate issue, so
good.
That does not require any sort of prior authorization. And then our vendor is obligated to turn those prior authorizations around in 5 days. That's what we hold them to. So if a person needed once a week therapy after that initial assessment, there'd be 3 weeks or 3 visits for them to get that therapy and for that prior authorization process to work through. If they needed something more intensive than once a week therapy, there are some other choices, but you've got 3 sessions, no time limitation on that.
Okay.
And then the more intensive services are different codes and therefore different, held to a different standard for prior auth.
And as we mentioned earlier, fraud is an issue, isn't it?
Fraud can be an issue. We'd make a big distinction between fraud and also improper billing. So when we have situations where we, for example, the previous policy where it was 26 sessions for those young people with no prior authorization, that's a lot of sessions that can get billed. If we don't know about that and it is not caught and it's not a real service, they're just sending us bills, there's no real service, which would be a fraudulent situation.
Sure.
Then that individual's benefits are maxed out and they didn't really get anything.
So to be clear,
we want to be careful about that.
Right, and so to be clear so everybody understands this, you could actually do 26 sessions for the young people without actually contacting Medicaid, but you are still billing Medicaid for that service, right? So Medicaid, first of all, you're looking for confirmation that the service actually occurred, correct?
Correct, and making sure that service is the right service for the presentation that the clients come in with.
But where does it start? It starts at vetting the provider. It starts assuring that the provider who's going to be providing the service to the client is properly vetted by the state to have the trust to go ahead and use their therapeutic judgment to use whatever interventions that this individual needs. We can't have the state defining how many units a provider who you are saying is good enough to contract with us and bill us now needs to defend why they're providing this emergency intervention to these clients.
So the therapeutic service shouldn't include emergency interventions if they're therapeutic services.
Sure, but you know, when it comes to mental health, these are chronically destabilized individuals.
Agreed.
And we don't look at it on the span of 3 weeks. These are people that have 3 years, 30 years of instability. So you're telling us within 3 weeks we can really assess how we can treat these individuals.
And that calls into question, is 3 visits enough to adequately determine the needs of each individual patient? And each individual is the big deal. And I know it's a subjective question, but...
Well, I want to go back to the fraud subject for a second. One, I think that we need to, educate some of our small end providers. We have a lot of tension with CMS with some of our larger providers, but not as much with some of our small end providers. But sometimes when they use the word fraud, I want to give a few examples so people can understand. So, for example, now we used to have 26 sessions. When I have a young lady that went to your agency and she used those 26 sessions, when that person comes to our agency, we have no idea what they did over there. I train my staff to see if they're open par, and I also train my staff to ask CMS if they can tell us, which CMS legally can't tell us, who has an open par with them or if they used their 26 sessions with someone else. So we're at a standstill. So when you come back and you receive an audit and they say, oh, well, this person has already used these 26 sessions, then there's some kind of, you find yourself in a discrepancy area. I also think training is important. Training for people to understand billing, how to go about billing. And also, we also know that the Affordable Care Act is being torn apart right now. And with the Affordable Care Act being torn apart right now, we know that there's a lack of income coming into the state from a healthcare perspective.
And Cody, what kind of training are they providing at the state level for this?
Yeah, I really appreciate Devin bringing that up. So, and that's where I make the distinction between fraud and what we would call improper billing. Because improper billing is really where some of those issues that you bring up that maybe the form wasn't filled out completely correctly, or perhaps the servicing provider and the billing provider got mixed up. Those are things we can educate on, and we come out regularly and meet with providers to discuss how to do those, how to correct those things. So before we start looking at any sort of fraud allegations, we want to make sure those things have been addressed.
Let's look at a little perspective, though, because I want to. The Review Journal recently reported the state data shows $738,084 was billed to Medicaid in 2013, the fiscal year 2013, for neurotherapy services. This year, as of April of this fiscal year, it had risen 2,345% to $18 million. I mean, that's roughly, I think, a 97% increase in the last 5 years. Something's going on here, and it's costing taxpayers and possibly patients who need services that aren't getting them a lot of problems.
Yeah, I'd love to speak to that. As someone who's an industry professional with the neurotherapy service, I would say that one of the biggest issues that's come up with my communication with the state is the lack of follow-through to some extent on addressing that the abuse. By the state? Okay. To address the abuse that had been occurring. Me personally, as an advocate for the industry, trying to protect the good businesses that are actually providing the service adequately, I have been reaching out to the state for many years to advocate for closer attention, to try and find ways of cleaning up this service through enhancing some of the regulation on it. But we hadn't done that. And with neurotherapy, that's an example where we say 26 sessions. For individual therapy, try 50 sessions without asking for a prior authorization. So we have a situation where we create an ecosystem. The state created an ecosystem. And the industry, as an industry, we have to self-police ourselves.
It's time.
And I was going to ask both of you real quickly, how do your organization self-police?
Well, we have a quality assurance team. And so we're taking a look at every aspect of our agency to see on a monthly basis what we can make improvements on, what things we may be able to change. But a huge part of our population is CMS, and we work off Chapter 400 for one of the chapters, which will be this behavioral health one. And that chapter is very vague at times. So it's up to It's up to your clinical supervisor, your medical supervisor, your team to speak with the state or Medicaid, because the Medicaid a lot of times will tell you refer back to Chapter 400.
And can you clarify CSM in Chapter 400 for us?
Chapter 400 is a chapter that governs our providership for those who provide whether it's substance abuse, rehab, outpatient services, or outpatient mental health services. They're governed underneath that chapter.
And you have to deal with the same thing, Steph, right?
Yes, I do. Yeah, so Chapter 400 does specifically deal with mental health and substance abuse services. But going back to your question, how do we police ourselves? We do similar things. We have monthly supervision meetings, sometimes even more frequently. And then now the state requires a quality assurance program that must be reviewed and submitted every year too. And so that has a list of things that we need to do and check and to make sure that we are providing quality services.
So back to and I don't mean to cut you off, but we're running out of time. Back to what's going to happen. Policy changes August 15th. Is the state prepared? Is the state ready for it's probably not a fair characterization, but the onslaught of people asking for not only services, but appeals and things like that?
The state is prepared. We've got services ramped up for those appeals because, as you point out, a denied prior authorization can be appealed and re-reviewed because we want to make sure everybody we're serving gets what they need.
Okay, the turnaround time, as Devin described it, under the old system, roughly 14 days. Am I characterizing that correctly?
It's roughly 14 days if everything goes perfect.
If everything goes well. The turnaround time now, what's it going to be?
So from the time that the prior authorization request is submitted to the time that it's processed by our vendor, we have a contract with them that gives them 5 days for that. So some of the other processes that Mr. Brooks was describing are internal to his situation. This should be transparent to the client. It is additional work for the providers in making sure that we're getting the right services to the right client.
Stephen, do you see that happening in 5 days?
No, I do not. I think the state, unfortunately, is not paying attention to the administrative burden that's going to occur to the industry. Mental health doesn't work like a Swiss watch. You know, a mental health client does not operate in time. And we have to be more, kind of savvy to those issues.
And Casey, to go back to your question, is 3 sessions enough? I don't think it's the number of sessions. I think it's the paperwork and the administrative work that goes into creating the prior authorization and the treatment plans that need to be submitted. So it's beyond the clinician. It's all the administrative work that has to go around that after the 3 sessions.
What happens in crisis situations? Because sometimes it's life and death. Sometimes it is.
Yeah, I'm glad you mentioned that. There was a service that we provided called Intensive Outpatient Programming Services. And in that Intensive Outpatient Programming Service, you provide several different services in that. Well, August 1st, the law came out that they're only going to approve 3 hours. Well, we had people in our program who was coming 4 days for 3 hours, or maybe 5 days, depending on if they maybe just got out of an inpatient facility or not. But Medicaid now is saying that you cannot do that. So now I have rural locations where we're providing intensive outpatient programming services, and now we're not approved to provide those services. And if we are approved, we're not allowed to do any other services. So if they need psych evaluations, if they're in a crisis situation, if they needed case management or anything, they couldn't receive anything.
Go ahead, Steph. You're chomping at the bit.
Well, like Mr. Brooks and I, we have organizations, we have agencies, administrative staff, but then if you look at mental health providers as a whole, you also have clinicians that have private practices. They're single individual providers where they don't have the administrative assistance to help with all of this. And I think there was a study that came out by the Behavioral Health Workforce Development Research Team that actually says the reason Nevada has one of the lowest rates of clinicians, mental health counselors, substance abuse counselors, psychiatrists, and psychologists is because of the amount of administrative work that goes into some of the services that need to be rendered and the instability of the reimbursements of insurance companies.
Cody, would you like to respond?
Well, I think Mr. Brooks brings up a good point that there were some changes to the IOP model that limited the amount of additional therapy services that can be done when people are participating in IOP programs that are 3 hours a day for multiple days a week. I think it's not entirely accurate that no other service could be provided, but we could definitely talk more about that. The administrative burden is an issue, and we need to work on that. Stephen makes an excellent point that You mentioned Chapter 400. That is Chapter 400 of the Nevada Medicaid Services Manual that's administered by DHCFP, which is Nevada, and we partner with CMS, which is the feds, just
Okay.
for clarity.
Thank you very much.
And that chapter can always be improved, and we are continuously making changes to that. And we need to work harder on making sure that these voices are included. That's why we have our public workshops before our hearings when policy changes are being made.
Some say that this policy change will make it so the underserved categories of the population will not have a voice, or their voice will be weakened or softened. Is that the case? How will the people who are underserved? I understand that people of color sometimes maybe have some problems, and I know you want to address that. We'll do that in just a second. But how can we make sure that everyone is heard?
So from our point of making regulation and policy, we have some very strict rules about how we can make sure everyone is heard. But the bottom basic line is they can always contact the Division of Healthcare Finance and Policy so that we can get that information.
What's the best way? Phone, internet, email?
We have an internet, we have a website that allows them to send us comments. Telephone always works. The issue of cultural competency and making sure that we have providers of various cultural backgrounds is one that's very urgent to us. Most of our population is served by our managed care organizations that you mentioned, and they are all obligated to provide a plan about cultural competency. Those plans can always be improved, so working on that is incredibly important.
Devin.
It's important for the state to understand what's happening. From a diversity standpoint, it affected us tremendously. For the minorities in this community, it has been extremely challenging to be part of or be affiliated with the managed care organizations.
Why is that?
Managed care organizations receive money from the state. They have the biggest contract with the state. With this funding, the state gives them incentives for not spending the money. So it's only obvious that these MCOs are probably most likely not going to spend the money. These people are, well, for my agency, I have an agency in the rural areas, I have an agency in the underserved areas. That's what Medicaid is funded for federal government and state funding for these people. If the state gives all their money to the MCOs, so if Health Plan Nevada, Aetna, and Silver Summit take 90% of the clientele base, and there's only a small clientele base, well, a person such as myself who grew up in this community, and my services are still in that community that I grew up in, and I see people from that community who want to come receive my services, I have to tell them that they can't receive my services because they have to go to Health Plan Nevada.
So, and to both of you, how do you solve that? Do you have solutions for that?
We've been trying to get, according to the Department of Insurance, I think we have about 88 psychiatrists. I have 3 of them. I've been trying to get credentialed with them now for 8 years. I don't know one other minority that's credentialed with Health Plan Nevada.
Well, I mean, we go through the same credentialing process, obviously, with the MCOs as well. And I think this shift with the managed care organizations coming into our community is a new thing, I mean, just in the past several years. So prior to this, the MCOs were not here. And I think that better training and education on understanding the MCOs will greatly help our providers, because then we can better be informed as to what we need to do to get on some of these panels, rather than being confused and not know. And some providers don't know how to get on the panels, don't know what they need to do to get on these panels.
So going forward, and I'm going to go back a little bit before we go forward, Medicaid for All was AB 374. It was passed in the last legislature. The governor vetoed it because he said it just wasn't comprehensive enough. It's most likely, and I'm going to ask your opinion real quick, will that be reintroduced, and how do you feel about it? Anyone?
I had a bill last year. I don't know too much about that bill.
Okay.
But I had a bill that I proposed that dealt with trying to get the state that if you lived in an underserved area, that you wouldn't have to necessarily go through the MCOs. When you have Health Plan of Nevada providers in Summerlin, when you have Health Plan of providers out in Blue Diamond, but you don't have these providers on Martin Luther King or on East Las Vegas, you lose these providers. And what these providers start to say is, I don't need to work with the state. I can go do commercial. I take cash pay clients.
Running out of time here, Stephen, I'm going to give you the last word. Is it possible to draw all this in and make it work within the time frame?
Yes. It is possible. I think this discussion makes it possible. I think we're all here, we're ambitious, we're youthful, and we're really spirited to make this conversation happen. And so I thank Ms. Cody as well for being a part of this and just giving us an opportunity to voice our concerns and to hear what the state's position is. And yes, we can interface this.
It sounds like there's a lot of work to be done, but it sounds like a lot of bright minds are working on it. Thank you so much, all of you, for being with us. We would like to thank all of our guests: Cody Finney, Deputy Administrator of the Nevada Division of Healthcare Finance and Policy; Devin Brooks, of course, CEO of Brooks Health Services; Stephen Brotman, Industry Advocate and Consultant; and Stephanie Huey, CEO of Illuminations Counseling and Homestead Counseling. Now, if you'd like to learn more about what we've just talked about, please go to vegaspbs.org. And if you have a question or a topic you would like us to explore, please email us at nevadaweek@vegaspbs.org. That's it for this edition of Nevada Week. I am Casey Smith. Thank you very much for spending part of your Nevada Week with us. We'll see you next time.